Very good morning and welcome to the 7th series of the IST Masterclass. I am Matthew Philip, the Secretary General of Indian Society of Gastroenterology. The previous masterclasses have been exceptionally well attended across India and several neighboring countries, reflecting the growing academic enthusiasm for this initiative. We started this during the COVID time, but we continued, and this is a very well accepted platform for training postgraduate students and young gastroenterologists across India. Today, we are delighted to bring you yet another very important and relevant topic, acute pancreatitis. It is my privilege to warmly welcome our distinguished speaker, Professor Pramod Garg, President of Indian Society of Gastroenterology, as well as the HOD, Department of Gastroenterology at All India Institute of Medical Science, Delhi, and our esteemed moderator, Professor Sudipta Dar Chaudhary from CMC Bangalore. Today's webinar will run for 1 hour and 30 minutes, and session will be conducted in two parts, with a 15-minute break in between, and we'll conclude sharply at 1 p.m. During the break, we will have the question and answer, and I request all the participants to post their questions in the chat box, and we'll make all effort to address the questions during the discussion time. Thank you once again joining us, and I now invite Professor Sudipta to begin the session, introduce the speaker, introduce the topic, and conduct the session. Thank you.
Thank you, sir. It is my pleasure and honor to introduce the speaker for today. I think Pramod Garg sir does not require any introduction per se. He is the professor and head of All India Institute of Medical Sciences and is currently the president of the Indian Society of Gastroenterology. Sir has worked extensively in pancreatology in different aspects of pancreas, both basic and clinical sciences. And I don't think so there's any other person who can give a better insight onto this topic of pancreas, that is the evidence-based management and predictors of severity of acute pancreatitis. So without much ado, I would like to request sir to take the stage. Thank you so much, sir.
Thank you, Professor Matthew Philip and Professor Sudipta Dar Chaudhary, for giving me this opportunity to talk about acute pancreatitis today and for a very kind introduction. Maybe I can share my slides now and we can begin with the deliberations today. So my job today is to talk about acute pancreatitis, predictors of severity, and evidence-based management. As we all know that acute pancreatitis is something which is very common, at least in the GI practice and also surgical practice. Even in internal medicine, we find a lot of patients are admitted with acute pancreatitis. In fact, this was one of the most common indications for hospitalizations in the United States of America a few years back. And in most GI centers today, we find acute pancreatitis is the most common indication for admission. These are my disclosures. I'm a member of a steering committee of a clinical trial sponsored by Calcimedica and investigator in a trial by Panafina. Now, we know that acute pancreatitis is associated with both local and systemic complications. And when we talk about the local complications, these include pancreatic acinar cell injury and pancreatic necrosis, followed by development of fluid collections. And later, many of these patients develop infected necrosis. But in the beginning itself, if the local injury is significant, it can lead to systemic inflammation. And a marked systemic inflammation may lead to organ dysfunction away from the pancreas, involving primarily the respiratory system, that is the most common, and also kidney, and sometimes even cardiovascular system. So this is the paradigm of the local injury and systemic inflammation. Now, if you take you to the journey of the management of acute pancreatitis over the last 20 years or so, some of the milestones I will first give you. So it was 1991 when Bradley famously showed that no surgery is required for patients with sterile necrosis, followed there by Todd Barron actually showed that endoscopic drainage of walled off necrosis, what he called at that time organized necrosis, is possible. Thereafter, the first report of endoscopic necrosectomy was published in 2000. In 2007, the Penta trial was published in NEJM, which showed step-up approach is better than open surgery for infected necrosis. Later, we showed that conservative treatment is sufficient for a sizable proportion of patients with infected necrosis. And then 2018 and 19, two trials from Europe and US showed that endoscopic drainage is perhaps better than minimal invasive surgery for infected necrosis. And in 2021, Pointer trial from Dutch group showed conservative first approach is better for infected necrosis. And 25, today we have standard treatment of endoscopic guided drainage of infected necrosis by putting in a lamps. And we also do percutaneous drainage and percutaneous endoscopic necrosectomy. However, I must emphasize that we do not have any specific treatment for organ failure. And going forward, this is what we should aim for, prevent necrosis, and we have to have a treatment for organ failure. Now, what has happened is, apart from the necrotizing pancreatitis, necrosis, infection, there have been many important developments on fluid management, analgesics, nutrition, antibiotics, and ERCP in acute biliary pancreatitis. So this is what most people think the treatment for acute pancreatitis is as of today, that you have a large walled off necrosis, you have this fancy drainage system of lumen opposing metal stent, one-step treatment, just go in and drain it out. And also there are other similar treatment modalities like percutaneous drainage. This is endoscopic drainage, and then by surgery you can have ward for necrosectomy. But this is not something that I'm going to discuss in detail today. I'm going to take you through the initial management of patients with acute pancreatitis, particularly severe pancreatitis, which is characterized by organ failure. Now, we all know that the Dutch group has published multiple randomized trials on various aspects and have shown that how we should treat patients with acute pancreatitis. Now, this is a very important paper to my mind published in 2019, where they showed characteristics of organ failure and infected necrosis on mortality. Now, please look here. Patients with persistent organ failure, the mortality was 44% in the Dutch patients. Those who had organ failure and later developed infected necrosis had mortality of 29%. The reason why the mortality in those with organ failure is higher is because these are the patients who develop organ failure very early in the course of the disease and may die early. And we'll come back to that. So let's move to the basics before I move forward regarding the treatment of these patients. So I just showed you this slide of how local injury, which is significant, may lead to systemic inflammation and organ failure. How does it happen? So in the first 24 to 48 hours, there is SNR cell injury and death. So this is the SNR cell, and multiple cellular stresses take place. There is abnormal calcium signaling, there is activation of pancreatic enzymes, there is endoplasmic reticulum stress, and impaired autophagy. And there are experimental evidences for each of these stresses, and these cellular stresses, if they are significant, they lead to SNR cell death. Now, in the first 3 to 5 days, there is also, in addition to the SNR cell death, there is pancreatic gland necrosis. So a cell may die either by apoptosis, which is a kind of a programmed cell death, doesn't really induce much inflammation. But if it dies by necrosis, then it releases a lot of substances which are known as damage-associated molecular patterns, or DAMPs. And these attract a lot of inflammatory cells because the immune system gets activated now, leading to inflammation. So in patients who have cellular necrosis, inflammation sets in early and maybe quite a bit. So this is, if you look at experimental models of acute pancreatitis, this is how one sees cellular necrosis under the microscope. So this is for example, a normal looking cell here, but this is a cell death. So there is necrosis here, right? On the other hand, when you as a clinician will see a patient with acute necrotizing pancreatitis, you find this is a enhancing pancreas on a contrast enhanced CT, and these are non-enhancing areas here which are necrosed. So there is a difference between the cellular necrosis and glandular necrosis. So what are the drivers of pancreatic necrosis? So these are activated enzymes, particularly lipase and trypsin. And the second mechanism is ischemia. So what is the role of pancreatic enzymes? So way back in 1980s, many studies done through experimental models in mice showed that there is activation of digestive enzymes which co-localize. That means the zymogen and lysosomal enzymes co-localize, and it is the cathepsin B which activates trypsin, and then trypsin activates other enzymes, and these activated enzymes cause cellular injury. So again, multiple studies over the years have shown the same thing again and again through experimental models. Vijay Singh from Mayo has also shown in multiple studies that the role of lipase is very important, and it causes lipotoxicity. So when lipase causes fat necrosis in and around the pancreas, both inside and outside the pancreas, it causes lipotoxicity by release of free fatty acids, which are injurious to different organs and may contribute to development of organ dysfunction. The second mechanism is circulatory changes, which are very important in the development of ischemia and pancreatic gland necrosis. So there are evidences from histology, both in humans and experimental models, and necropsy studies showing microvascular thrombi within the small vessels inside the pancreas. Many studies have also shown that there is increased D dimers in patients with acute necrotizing pancreatitis and also elevated plasma tissue factor in severe acute pancreatitis. So Dr. Sudipta Chaudhary, who is moderating the session, has published a very important study a couple of years back where they showed that there is imbalance in the von Willebrand factor and ADAM-TS13 axis early during the course of acute pancreatitis, and it actually predicts development of persistent organ failure and necrosis in patients with severe disease. So if you see here, the von Willebrand factor is higher in those with persistent organ failure, while the ADAM-TS13 activity is lower in them, significantly lower. So it is believed that in those with necrotizing pancreatitis, severe disease, there is a kind of a procoagulant state which leads to ischemia. And what is happening is that there is an inflammation-induced endotheliopathy, excess ultra-large von Willebrand factor are released, and there is relative insufficiency of ADAM-TS13. So these lead to procoagulant state and microvascular thrombi. Do we have evidences of ischemia? So the best way of finding out ischemia in an organ is through the use of perfusion CT scan. So perfusion CT scan, what it does is, if you do it in the early phase of the illness, it can actually quantify the perfusion in a tissue. So this is a perfusion CT scan in a patient with acute pancreatitis. And if you see here, this is the pancreas. There's a small area of perfusion defect on a perfusion CT like this. And when you follow up this patient after a week or so and do a repeat CT, you find in the same area there is gland necrosis. That means if the blood supply was less in the beginning, in the same area, they will develop necrosis in the pancreas. Another example, in this patient, you find there is significant perfusion defect throughout the pancreas. And when we repeated the CT after a couple of days, after a couple of weeks, we found almost the entire pancreas was necrosed with a large necrotic fluid collection here. So the first report of perfusion CT actually came from Japan. And subsequently, we did a study and we found that the sensitivity and specificity of perfusion CT is high for early diagnosis of pancreatic necrosis. But more importantly, it reinforces the belief that there is perhaps ischemia of the pancreas, which leads to or contributes to necrosis in these patients. So this is the conceptual model of injury. You have first cellular injury or tissue injury, which leads to development of inflammation in and around the pancreas. And if this inflammation, local inflammation, is severe enough, it spills over to the systemic circulation and may lead to organ dysfunction. Local injury here, then you have the activation of different immune cells and inflammatory cells, which leads to organ dysfunction. So I will give an example of patients who came in with young man, with acute pancreatitis, pain for 1 day. He developed respiratory failure on day 2, renal failure day 3. He was hospitalized. He was in ICU on a ventilator, dialyzed, but died on day 7. So this is the situation that you see occasionally, young patient without comorbidities. Major problem is organ failure here. So we did a study many years ago where we characterized these newer subgroups of patients with what we call fulminant and subfulminant pancreatitis, which were associated with high mortality. And in a study of 282 patients, in those who had early severe acute pancreatitis, we defined fulminant pancreatitis if they had grade 3 or 4 organ failure or multi-organ failure of at least grade 2 within the first 72 hours of the onset of acute pancreatitis. And what we found was very interesting, that 11% of patients of the entire cohort, they accounted for 44% of all deaths within the first 8 days. Now, this was at a time when pancreatic necrosis infection, whether are absent or evolving. Now, if you recall my initial slide where I showed you the mortality in patients who had severe disease, persistent organ failure in the Dutch cohort, they had 44% mortality among patients with early organ failure. So this is what happens. Those who have early persistent organ failure, the mortality is very high. So many of these patients, once they develop necrotizing pancreatitis and necrotic fluid collections, they may develop secondary infection, what is called as infected necrosis. And then subsequently, if this infection is severe, it may again lead to organ failure, involving most commonly respiratory and renal dysfunction. So that means we have 2 kinds of organ failure here. So this is what we studied published in 2018, that primary and secondary organ failures cause mortality differentially in patients with acute pancreatitis and should be distinguished. So this is the paradigm here. You have pancreatic inflammation, tissue injury leads to release of DAMPs, which leads to systemic inflammation, which clinically manifests as systemic inflammatory response syndrome or SIRS. And this leads, some patients develop infected necrosis, which may cause secondary organ failure. So this is a study of 614 patients. 177 developed primary organ failure, 283 developed infected necrosis, and 97, about a third of them, developed secondary organ failure. Mind you, these are the data from a tertiary care hospital. Because of the referral bias, we get more patients who are moderate to severe pancreatitis and very sick patients. So what we found was that those patients who had primary organ failure, 177 here, 152, majority of them had early organ failure within the first week. And 15% of them died within the first 2 weeks. Those who survived the first 2 weeks, 84% of them, then 76% developed infected necrosis. This is a very important point. That means those who had early organ failure are prone to develop infected necrosis. And this has implications for treatment later. And their mortality was 42%. So if you have early organ failure and develop infected necrosis, mortality is 42%. Now, you may find that the mortality is very high in our patients, but if you see those who didn't develop infected necrosis, mortality was only 13%. So when we compared our data from other series, so this is 2018 that we published from AIMS. This is the Dutch paper that I showed you earlier and published in Cut. And this is the Spanish paper published in Annals of Surgery, all at the same time. We had 805 patients, 639 and 1,600 patients here. If you see the mortality in those with persistent organ failure, 42% here, 38% in Dutch group, and 52% in the Spanish group. Very high mortality in these patients. Now, before I move further, I like to give you some other examples where we find organ failure may not be really due to acute pancreatitis. These are some caveats that you should understand. So this is an example of a young boy who came with severe abdominal pain. He had no fever. He had decreased urine output, developed hypoxia and altered sensorium. He was on a ventilator, dialyzed. Etiological workup was negative. And if you see his parameters, he had low hemoglobin later, high counts, platelets started decreasing, amylase lipase were very high, and creatinine reached to 2.2, mildly altered liver function test. So we could not diagnose. We thought it is severe acute pancreatitis, treated him conservatively. He was with us only for a day, and we found that on peripheral smear showed plasmodium, falciparum here. And this patient had fulminant malaria, cerebral malaria, and died within 48 hours before we could do anything here. So here the pancreas was involved separately. It was not the primary disease. Another young female came with symptomatic gallstones in the past. She had severe abdominal pain, no jaundice or fever, decreased urine output on day 3, was on dialysis. She developed altered behavior and shortness of breath. Amylase lipase were high. Ultrasound showed a bulky pancreas and moderate ascites and cholelithiasis. Again, diagnosis of severe biliary pancreatitis was made. She was planned for an upper GI endoscopy for putting in a nasojejunal tube. And what we found on endoscopy was large necrotic deep ulcer in the interior wall of the stomach, incisura and greater curvature, and biopsy showed mucormycosis. So she never had pancreatitis. Pancreas was second involved, and she was actually operated and found to have a large necrotic ulcer, which had perforated posteriorly as well. So she was started on M4B, but we could not save her, and she died within 2 days of surgery. The third patient was again a young male who came with abdominal pain, high-grade fever, and jaundice, no decreased output. On day 6, he developed hypoxia, anemia, and thrombocytopenia. Ultrasound showed bulky pancreas. His leptospira, serology, and scrub were both positive, and he improved with doxycycline and discharged. So what I have shown you these 3 patients is that not all organ failure are due to severe acute pancreatitis. If there is very early organ failure, we should be alert about the differential diagnosis of a primary disease, which is also secondarily involving the pancreas. So it's not the severe pancreatitis causing it. And why it is important to understand this is that these are the patients who may be saved by giving a specific therapy, for example, for an infectious disease here. Now, I'll just take a minute before we have a break, because Dr. Matthew Philip told me that we'll have a break after about 20-25 minutes. So prediction of severity is an important concept for triaging, for referring patients to another center. And you have to explain to the relatives whether this patient is how he's going to behave, what's likely clinical course, whether it's survive or not. So there have been enormous amount of data on prediction of severity. So there are both multiple scoring systems, Ranson's, Apache 2, Biceps. These are the ones. So Bicep and Apache 2 are still in vogue. Ranson's has already almost been given up. And there are certain single prognostic markers. The 2 that I have picked up will be CRP and IL-6, and I'll tell you why it is important. But I tell you that surely we need to do these multiple scoring systems and single prognostic markers. We measure them quite regularly. These are important for reporting your studies so that we have uniformity across studies. And also, these are important from the point of view of coming out with newer information in large cohorts of patients. But if you have to treat, you are seeing the patient for the first time, for example, the best clinical marker to predict severity is if there is already persistent SIRS for more than 48 hours, or there are now signs of organ failure. So I would only advise you can forget about all the markers, whether they are multiple scoring systems or single prognostic markers. Just look at SIRS. If SIRS is present and more than 24 hours, you start getting worried. If it is persistent more than 48 hours, you should be worried, because this is the patient who is likely to develop organ failure, and you must refer to a higher center if you do not have the facilities to treat at your center. And someone who already shows features of organ dysfunction, even if it is grade 1 or grade 2, single organ, you should be worried, because now you are dealing with severe pancreatitis. So the difference between prediction of severity and severe is this. So when we talk about, say, revised Atlanta classification, I say this patient has mild disease or a severe disease. That is only after the clinical course has finished. That means after 3 weeks, 4 weeks, 6 weeks, I can tell you that this patient has severe disease because there was severe organ dysfunction in the beginning. Or this patient had infected necrosis, so it fits in the category of moderately severe pancreatitis. But if a patient comes on day 1 or day 2, then I have to predict that severity, whether he's likely to develop necrosis or not, whether he's likely to develop organ failure or not. And prediction of severity is best by persistent SIRS and signs or features of organ dysfunction. So before we move on to the management, it's about 25 minutes that I've been speaking, 22, 23 minutes. Dr. Philip and Dr. Chaudhary, do you think I should stop sharing now, and maybe we can take some questions as you mentioned earlier?
Yes. Now we can have a break of 15 minutes, during which we can have the question and answer session. I request Dr. Sudipta for taking up the questions and discussing along with Dr. Pramod Garg.
So there are like hordes of questions actually, and I think this is a very hot and burning topic. So I'll start off with the questions which are primarily related to this particular session. In this half of the session. So one of the questions that is very interesting is someone asked questions is there a role of endotyping in acute pancreatitis as in sepsis and bronchial asthma?
Thank you, Sudipta, for a very important question. So now, let me give you a brief background, because many of the listeners and attendees may not be knowing about this issue of endotyping. So revised Atlanta classification, for example, which is the most commonly used, will tell you about 3 categories: mild pancreatitis, moderate, where you have local complications, and severe pancreatitis, where you have persistent organ failure, right? But if you look at patients with severe disease, severe pancreatitis, those who have organ failure, you find there is a lot of heterogeneity there. Some patients will survive, others won't. Some will survive in 3 to 4 weeks. Others will be in the hospital for about 8 to 10 weeks or maybe more. And similarly, you have patients who develop infected necrosis, others don't. Some develop local complications, others don't. Now, this is regardless of the other clinical variables. For example, young patient versus old patients, male versus females, comorbid conditions versus no comorbid conditions. Now, similarly, if you look at patients who have got infection, for example, those with pneumonia. So those with pneumonia have normally a course in the hospital for about a week or 10 days. But some patients develop sepsis. Sepsis means there's a dysregulated immune response and they develop organ failure. Now, it was realized that among patients with sepsis, there is again a lot of differences and variability with their clinical outcomes. So then people thought, what is the cause for that? And they did transcriptomic analysis in these patients and showed that their immune response to that infection is variable. And they're divided into different molecular endotypes. For example, somebody may have myeloid dysfunction, somebody may have lymphoid dysfunction, somebody may have combined dysfunction, and somebody might have a balanced response. And of course, those with a balanced response will have a best outcome. Now, similarly, there are now initial attempts in trying to understand that are there molecular endotypes among patients with severe pancreatitis and organ failure? And I think there is only preliminary data here. Dr. Sudipta Chaudhary has published a paper very recently on this, and there are many groups which are now trying to understand this issue and study it in great detail. Thank you.
Thank you, sir. Thank you for putting. So there are a lot of questions, mostly on the management aspect. I have one question, which I'm asked quite often by registrars actually, and I'll put it forward like this: that we use the modified Atlanta and say that patients coming more than 48 hours organ failure persistent for more than 40 years to be severe or moderately severe. However, many of our patients have disease onset more than 72 hours or 80 hours before the onset of disease. Is this modified Atlanta relevant to us? Number one, in Indian context where the patients are getting admitted late. And if admission is late, if a persistent organ failure is there at admission, can we call them a severe at the beginning itself?
No, but I think conceptually speaking, whether the patient comes to us early or a little later in the course, if you find patients come to you on day 4, 5, 6, or 7, and there is already organ failure. Now, your question could be whether this organ failure is primarily driven by the dysregulated immune response, or there could be a contribution of less than optimal management before the patient came to you. For example, we are going to talk about that. Somebody who has not been resuscitated well, somebody who has not been giving adequate fluid, somebody who has not been, whose hematocrit is very high. And you may find that these are the patients who may develop more severe disease. So then the issue is whether the patient received adequate treatment outside or not. But other than that, if a patient comes early or late and you find there is a rapid progression to develop organ failure, then you're dealing with severe disease.
So another question in the chat box is, can we arrest this progression to severe pancreatitis? If the patient presents to us early, is there a critical window before which intervention can prevent progression?
So I think theoretically, yes, we can. Practically, as of today, I'm not sure we have the right strategy. But this is what I'm going to talk in the next half an hour or so, 20 minutes or so. How can we prevent it? And this is going to be an important focus of my talk.
I think the other question which was there in the chat box was about the currently available scoring system, which you personally find most practical. And I think you've addressed this very clearly that SIRS is more than enough. And we are probably, there are plethora of scoring systems right now at different time points, different scoring systems. And maybe sometimes in a same patient, a different scores at different time intervals may be also relevant. And the other question was on, of course, this is more in the first part, but there was a question from the group was markers of severity, predictors of early. I'm just skipping that part. Are there any emerging biomarkers that may improve early prediction of severe pancreatitis in the near future in terms of AI tools, imaging techniques, perfusion scans? I think one study you already alluded to in your talk that CT perfusion, etc.
So I think, again, this is a very important question that can we use AI, for example, large language models to understand the biomarkers which can predict the course very early? And I think definitely yes. So if you have large data sets available, prospective cohorts, then you can certainly train the model. And what we know today is that if the calcium is low, if your pH is low, if you find the TLC is more than 16,000, if you have hematocrit which is high, we know these markers are there. But I think if we have multi-center studies, prospectively conducted large cohort, and already there are multiple studies available, and we can train those models through AI, we can certainly find newer biomarkers. And I know there are some efforts going on in that direction. Perfusion CT, the only issue with perfusion CT is that it can tell us about the likely perfusion defect, but as of today, we don't have a mechanism to treat it. And again, it raises an issue of radiation to these patients, because in perfusion CT, you have to give a lot of radiation.
So the other questions in this section on the thing is that how can you differentiate, as I think it's primarily related to the last few cases that you showed, like how to differentiate primary pancreatic involvement from that due to primary disease involving the pancreas from something which is secondary an effect of organ failure?
So again, a very important point here. If you find that the organ involvement is multi-system, very early, and out of proportion to the abdominal problem. You examine this patient, you find the abdomen is soft, there isn't much tenderness or guarding, there isn't much ascites. You do a CT scan, you find there is not much pancreatic or peripancreatic necrosis, but there is a lot of inflammation. There is some ascites, bilateral effusion. Your platelet starts decreasing on day 2, day 3, and there is some liver dysfunction. Now, you know this patient is likely to have a multi-system disease, which is unlikely to be due to acute pancreatitis. A history of fever at the onset of the disease again suggests an infectious illness. So there are subtle multiple clinical markers which can alert you towards the diagnosis. And I can tell you preliminary data from our center, we are doing a prospective study on that. About 12 to 15% patients may actually have an infectious etiology for acute pancreatitis, which we earlier thought is likely to be idiopathic. But if you dive deep into it, you do multiple investigations, you find some of them will have virus infections, leptospira, scrub, or other infectious etiologies. Hepatitis A, E, we all know can cause that. So please look for those infections, and that will give you a better idea about how to treat these patients.
Most of the questions in the chat box are primarily related to the management per se, not really to the pathogenesis aspect. I think, sir, you're talking on this in the next half of the session, sir.
So there, I'm also seeing some of these questions. Among the current level marker, which do you think personally find most practical and relevant day-to-day clinical practice? So again, which I've said that SIRS is the best predictor. Among the single prognostic marker, today I believe that IL-6 is something that is very important. And I'll show you some data on IL-6 later during my talk. So after COVID, what happened that we started doing IL-6 almost regularly, because then it became available in all the labs. And we find that it is a very good marker. If you come to single prognostic markers, then IL-6 again is an important single prognostic biomarker which can tell you about the disease trajectory.
Professor Garg, at what time will you do IL-6 at the time of admission, or you repeat it?
Yes. So at the time of admission and within the first few days, if your IL-6 is more than 150, it tells you that it's going to be severe disease.
Do you repeat that, or only one value is enough?
So I'll show you some data on this. So if you do multiple times, then you know if the trajectory of IL-6 actually correlates with the clinical outcomes.
Just one more question. A patient comes with acute severe pancreatitis, and the patient is in SIRS and failure and all. What do you think? Who should treat the patient? Is the gastroenterologist or critical care or combined? What is this is actually many times a confusion in at least in certain hospitals. I have seen this. So what is your experience? What is your feeling? And I request Sudipta also answer what is the experience on Pramod first.
So I would say that patients with severe pancreatitis who have already developed organ failure should be managed in an intensive care by an intensivist along with gastroenterologist, because these patients require very careful management, because one thing goes here and there and you can have a very worse outcome, very different outcomes. So ideally they should be managed by an intensivist along with a gastroenterologist. But the gastroenterologist is really required because you know the intricacies of the disease process, right? And which we are going to soon discuss. But a combined effort is definitely the way forward.
Sudipta, how do you do that?
I completely agree with in this aspect. And I think severe pancreatitis is a very, very complex disease. It cannot be managed by one team alone. There is a respiratory involvement, cardiovascular disease, etc., and ventilatory settings sometimes. So I think the critical care physician in consult with gastroenterologist and the surgeon would make the ideal team to manage acute pancreatitis. At this point of time, we need a team-wise effort. It's an extremely intensive disease.
Yeah, absolutely. I think there's a very good message that it's not G management alone. You would require more than that in these patients in the critical phase. Any other questions on this? Otherwise, we'll move on to our next talk.
We'll go to the management, sir, because a lot of questions are coming from the management aspect.
Sure. Okay. Thank you. So coming to the management, the issues are when do you refer a patient to a higher center if you don't have those facilities? What is the initial management of these patients, which involves analgesics, fluid therapy, antimicrobials, and nutrition? What is the management of organ failure? Can we prevent it? How do we best treat it? And management affecting necrosis and complications. But the last topic is something that I'm not going to discuss in detail today. So, as I just said, clinical markers are best in terms of persistent surge and organ failure. Anyone who has that, you can refer these patients to a higher center. And as we just discussed, these patients are best managed in an ICU with the help of an intensive care physician. Now, coming to the initial management of these patients, I have drawn my recommendation based on the recently published International Association of Pancreatology revised guidelines on acute pancreatitis 2025. These were the guidelines developed by IAP, but supported and endorsed by American Pancreatic Association, European Pancreas Club, Indian Pancreas Club, and Japan Pancreas Society. In fact, I'm very happy to tell you that and there are at least more than 10 authors on this paper from India. So coming first to the analgesics, what is the right choice? So we have two options, opioids and NSAIDs. Both have some safety concerns. For example, NSAIDs may lead to renal failure or GI bleeding, and opioids may lead to ileus and respiratory depression. So there was not much data, and we conducted a randomized trial. Soumya Jagannath from our department did that, comparing diclofenac with pentazocine, and we found that pentazocine opioids was better than diclofenac, with the dose of rescue analgesia requirement was much less with the use of pentazocine. Pain-free period was longer in these patients, and total demand for rescue analgesia was lower. And we felt that it is better than opioids. In fact, now there have been two subsequent RCTs from PGI Chandigarh, and both have shown that opioid analgesics provide better pain relief. And if required, you can always supplement it with NSAIDs. Now, very recently, there is a guideline on pain management from the European Pancreas Club, and which was published in the UEGW journal very recently, where again they have shown that opioids perhaps provide better pain relief and should be preferred. And for those who still require rescue analgesia, fentanyl is very good. And what I would recommend is to have an infusion pump for fentanyl rescue analgesics. And this is very effective, and patients are very happy with this. One thing that we have noticed clinically, that if you control their pain better, their surge parameter go down. And often that shows how a patient can improve very, very quickly. Now, we do not know whether controlling the pain will decrease their inflammatory markers, but clinically you find that their surge parameters actually improve. So controlling pain is very important. The second aspect is IV fluids, and much has been discussed on this over the years, and multiple trials have been published. So I'll give you a gist or the summary of what is required. So in the first 1 to 3 days, there is always a confusion about the usual fluid deficit. How much is the deficit? What is the rate and type of fluid to be replaced? And how do you guide fluid therapy? So everybody now knows about this recent randomized trial from Spain and many other centers, the waterfall trial, where they compared aggressive versus moderate fluids. Aggressive was defined by a bolus of 20 ml per kg, followed by 3 ml per kg per hour. And moderate fluid was 1.5 ml per kg per hour, and bolus of 10 ml per hour only if there was hypovolemia or hypertension clinically. And what it shows was in 249 patients, the primary outcome was incidence of moderate to severe pancreatitis. It developed in 22% in those with aggressive arm and 17% in the moderate resuscitation arm. But more importantly, the fluid overload was seen in 20% in the aggressive arm versus 6% in the moderate resuscitation arm. And trial was actually stopped prematurely because of safety concerns. So why is that so? So we published this editorial in gastroenterology a few years back where we showed why it is so important to give optimal fluid. So let us understand what is happening in those with mild disease and those with severe disease. In patients with mild acute pancreatitis, there is no systemic inflammation. there are preserved neurohumoral mechanisms and capillary circulation is intact. Even if you give aggressive fluids, there is potentially no significant harm and no organ dysfunction develops. Now, contrast this with those with severe disease. In severe pancreatitis, I showed you earlier that there is pancreatic necrosis, and these immune cells and inflammatory cells are attracted. There's release of free fatty acids and various inflammatory markers, TNF-alpha, IL-1, IL-6, IL-18, which go to bloodstream, and that all these cytokines and free fatty acids cause primary organ failure involving multiple organs here. Now, if you give them, in these patients, there is endothelial injury. I showed that earlier, and which leads to fluid sequestration in the interstitium here. If you give more fluid to these patients, more fluid will leak out of these capillaries and then cause tissue edema, decrease intravascular volume, tissue hyperperfusion, and will contribute to organ dysfunction. So you had organ dysfunction because of the marked inflammation. You give more fluid will go to interstitial space and cause further problems. The other thing we should all remember is that how much fluid is retained in the intravascular compartment. If you give a liter of fluid, only about 100 ml of water or 250 ml of lactate inker is retained. Rest goes out into the interstitium, and it causes more problems. Which fluid to give? We have a lot of clarity on that multiple randomized trials and meta-analyses have shown that ringer lactate is better than normal saline. How do you monitor these? So what are our goals which we want to achieve? A mean arterial pressure of about 70, hematocrit around 40 to 42, and urine output minimum is 0.5, but ideally is 1 ml per minute. And to achieve this, we have to give fluids. How do you monitor whether we are giving enough fluids or not? There are some invasive markers, but now everyone understands that central venous pressure is not a good guide, especially in those patients on ventilator. Ideal is invasive pressure monitoring through stroke volume and arterial pressure waveform, but most patients are not having any arterial line, and I don't think you should put in arterial line just for the sake of assessing this. But non-invasive techniques are very good by using bedside ultrasound. And I would recommend and encourage all of you to have this at the bedside. And all our residents actually have learned it. So it is not difficult for internists, for gastroenterologists to learn bedside ultrasound, where you look at the IVC diameter, and lung ultrasound for fluid overload. And it's very easy to see the IVC diameter and find out if there is fluid deficit or not. And lung ultrasound is something which can show you these B lines. If you find B lines there, you know there is fluid overload and you should stop giving a lot of fluids to these patients. Both these things are not difficult to do by gastroenterologists. So what is the current recommendations in patients with acute pancreatitis? It is reasonable to give about 3 liters of ringer lactate in the first 24 hours, and it depends on the fluid assessment and severity of the disease. Beyond the first 3 to 4 days, the intake should match the output, plus 500 ml for insensible loss. But in the first 3-4 days, 2.5 to 3 liters of fluid is reasonably good. But if you find your patient has a very high hematocrit of about 50, 52, 55, you have to give fluid to bring it down to about 44, 45. So hematocrit is a very important guide in addition to the non-invasive markers. This is very important regarding fluid therapy. We cannot convert a potentially severe disease to mild disease by giving more fluids. On the other hand, we may worsen severe pancreatitis by giving aggressive fluids. So be careful by giving aggressive fluids to patients who have predicted severe disease. Coming to antibiotics, I think a lot of things have been said about antibiotics. Obviously, there is no role for prophylactic antibiotics in either mild, severe, or necrotizing pancreatitis. In fact, now there are reports of major problems with prophylactic antibiotics in terms of development of resistant organisms and fungal infections. And multiple meta-analyses have shown that there is no benefit. One thing that has come up in the new IAP guidelines is that increased CRP, increased WBC count, or increased PCT alone should not be used to determine the need for antibiotics. Now, what it means is that if you have a patient who is in the first week or early second week, and you find the counts have 15,000, 16,000, or your PCT is now 2 or 3 or 4, that alone should not be taken as a marker for infection. There has to be a combination of clinical features and laboratory markers to say that I suspect infected necrosis in these patients. Nutrition, there is again a lot of clarity with regard to nutrition. The old concept of pancreas rest has been given up, and early nutrition is very important in both mild and severe disease, and it definitely affects the disease course. And there are always issues of oral versus nasogastric versus nasojejunal tube feeding, and what should be the target calories. The IAP guidelines very clearly says that in mild disease, oral feeding should be started as soon as possible. And I tell you, the clinical guide is as soon as you find patients' abdominal pain is decreasing, you don't have to wait till the abdominal pain is gone. It's decreasing. He's not actively vomiting. Then you should start oral feeding as soon as possible. In those with predicted severe disease, nasoenteric tube feeding is indicated, or those with established necrotizing pancreatitis within the first 72 hours of hospitalization. Now, practically speaking, sometimes it may not be possible for you to put in a nasojejunal tube, but within the first 4 or 5 days, you should ensure that there is enough calories are being given to these patients. Very important because it definitely affects the clinical course. Polymeric feeds are as good as monomeric feeds, so polymeric feed should be given. Your target calories are 25 to 30 kilocalorie per kg with 1.2 to 2 grams of protein per kg body weight. And we rarely rely on total parenteral nutrition. So give polymeric feeds, then it's good enough. Another newer recommendation which came in the IAP 2025 guidelines are regarding the hypertriglyceridemia associated acute pancreatitis. This was not in the previous guidelines. So insulin is recommended in diabetic patients who have increased triglycerides and acute pancreatitis, but insulin may also be considered in non-diabetic patients. Short-term use of low molecular weight heparin may also be considered in these patients. It's a conditional recommendation. And plasmapheresis may also be considered if there is persistent organ failure, particularly acute renal failure. So all these three therapies have been tried in randomized trial and shown some benefit. Now, coming to the most important question, how do we prevent or treat organ failure in these patients, and is there a potential therapy? So I've shown you earlier that there is a paradigm of local injury which leads to organ dysfunction. So many years ago, we asked this question, is there a correlation between local injury and systemic inflammation? And in a study of 276 patients, we found that the extent and infection of necrosis correlate with organ failure and mortality in these patients. And more than 50% necrosis, infected necrosis, there was a high risk of mortality. So that means if I have to prevent organ failure, we should try and prevent necrotizing pancreatitis. So I have shown you in the first part of my talk that there are two reasons why necrosis might develop. One is ischemia, the other is activated enzymes, particularly lipase. And there are now some hope that we can actually achieve something. So to prevent pancreatic necrosis, now there is a ongoing randomized trial of using anti-lipase. This is a phase 2A randomized trial to evaluate EUS-guided peripancreatic injection of orlistat. Orlistat is anti-lipase in predicted severe acute pancreatitis. So what is done here is that under endoscopic guidance, you inject this orlistat analog Rabi 767 in and around the pancreas and hope that this will help these patients by inhibiting the activity of lipase. And this trial was initially ongoing in the US, and now it has been extended to 4 centers in India. And both Dr. Matthew Philip here and Dr. Sudipta Chaudhary are part of this trial. And we hope that this should show us some positive benefit. The second strategy for preventing necrosis is by giving anticoagulation. As I showed you earlier, that there is ischemia in these patients with microthrombi. Low molecular weight heparin has been shown in some RCTs and a meta-analysis of 8 studies showed that it decreases significantly development of multi organ failure and decrease in mortality. However, the quality of evidence is low. There is a lot of heterogeneity among these trials and risk of bias. And that is the reason we need more data on that. So it does hold promise. And that is why we are now conducting a trial, a randomized placebo-controlled multi-center study on the role of enoxaparin in the prevention of moderate to severe pancreatitis. This is a double-blind trial across 10 centers in India. We are including recruiting patients with predicted severe pancreatitis within the 3 days of onset. Our sample size is very high, 482, and therapeutic low molecular weight heparin is being given for 7 days, and outcome is decrease in moderate to severe pancreatitis. So this is currently ongoing trial across 10 center. Dr. Sudipta Dhar Chaudhary is a part of that. Now, then after you have tried to prevent necrosis, and I think it will take at least 3-4 years before we have some definitive therapy, how do we treat organ failure if it has already developed or prevent it? Now, if you go back to the COVID times, we found that very few patients developed severe disease. Majority of those who had COVID infection are mild disease. So, and it was realized that this severity is related to what is called now as cytokine storm, which is sudden massive increase in cytokines in the blood. And this is again something linked to sepsis, dysregulated immune response. The virus was the same in the pandemic, right? But some patients develop severe disease because of massive increase in cytokines, which led to organ dysfunction. And it was at that time people showed that if you can control this, you may find that patients improve. So there was no study on cytokine storm in acute pancreatitis. We did a prospective study of 152 patients. 98 were recruited in the study. 40 developed cytokine storm syndrome based on the following criteria: high IL-6, organ failure, and higher in-hospital mortality in these patients. And we found that 2 cytokines were important, MCP1 and IL-6, which was significantly raised in those with severe disease. And as I mentioned during the discussion following the question answers, that IL-6 on day 3 correlates with organ failure. And in 2 studies, we have shown that high IL-6 and presence of SARS actually predict organ failure. And we have seen that IL-6 of 160 picogram per ml is a very important marker in these patients. So is there a potential therapy for that? So systemic inflammation is the critical element. And if we have to decrease the mortality, we have to have some targeted therapy for that. As of today, what we do is patients have early organ failure, they are in intensive care, we have intensivists, patients have multiple support, you pray and hope for the best. But there is no specific therapy. Antibiotics, nutrition, and type of fluids are important, as I mentioned earlier, but these cannot really prevent development of organ failure. So targeted therapy is required. There have been some efforts in the past. For example, Lexipefan 2006 randomized trial didn't show anything. Probiotics actually proved to be detrimental, and there were no trials after that. Activated protein C again didn't help. Pentoxifylline, one initial study showed some benefit, but a larger trial failed to show any benefit of pentoxifylline. So what do we do now? How do we have a targeted therapy? So I'll show you some promising data from ongoing studies which offer hope. So this is first study is extracorporeal removal of cytokines by the use of cytosorb. And there was a small study of 16 patients with severe acute pancreatitis, Apache 2 of more than 10. 2 consecutive 24-hour treatment with cytosorb was given. This is a study from Germany, and the primary objective was 20% improvement in hemodynamics, which was achieved in 68% of patients versus 28% in controls. So this was not a controlled study. And what we need is randomized trials on the use of cytosorb. As you probably would recall, the cytosorb had been used in patients with sepsis with some improvement, but it is not as yet standard of care. COX-2 inhibitor there was a study published 4 or 5 years ago which showed some benefit. But this is a recent study published from China as a randomized trial where they gave COX-2 inhibitor initially IV for 3 days and thereafter oral for 30 days versus placebo. They had a fairly large sample size of 348 patients, and they showed significantly lower organ failure and 23% versus 8% in the placebo in the COX-2 arm, and significantly lower mortality of 3.4% versus 8.6%. Now, one important caveat here is that 73 and 78% of their patients had organ failure at enrollment. And yet the mortality this is 30-day mortality of 3.4 and 8.6%. Even in placebo arm, the mortality was 8.6%. And I have shown you earlier that the mortality may reach as high as 40% across different studies. So we are really not sure what they meant by severe disease or organ failure, whether they really had persistent organ failure or not. But suffice it to say that COX-2 inhibitors do offer some hope in these patients. IL-6 I showed you is an important marker, and anti-IL-6 tocilizumab has been used in a small randomized trial of 20 patients with predicted severe pancreatitis. They were randomized to tocilizumab versus placebo, and at 48 hours, they showed significantly higher reduction in CRP, minus 41% versus plus 31, and there was obviously no difference in mortality because the sample size here was rather small. But this again tells us that we need a larger randomized trial on anti-IL-6 therapy in these patients. There are some other promising trials. TNF alpha antagonist, there is an ongoing randomized trial in the UK. They have already enrolled about 70 patients. Robert Sutton is leading that trial, and they are including all patients with mild and severe disease. So we await the results of that. We did a randomized trial with omega-3 fatty acids. So I showed you in the beginning that free fatty acids actually may be detrimental, and all the pro-inflammatory cytokines, many of them are based on lipids. And omega-3 fatty acids have been shown to be of some benefit. So in a randomized trial of 82 patients with severe pancreatitis, we found that there was a decrease in the organ failure score up to day 28. However, we did not reach statistical significance in this study. Perhaps there was a beta error. And we are currently doing a meta-analysis of multiple randomized trials, and we are finding that perhaps there is some merit in using omega-3 fatty acids, but we can't tell you as of today because these studies are still ongoing. Now, in the beginning, I showed you that there is SNR cell stress and activated enzymes. Calcium signaling is very important within the SNR cells and also within the immune cells. So calcium channel inhibitor, ORI1, which is a company has manufactured by the name of Oxera, has been shown in experimental models that it may decrease the severity of pancreatitis. So a phase 2b trial has been completed of Oxera, and it has been shown that high and medium doses decrease time to solid food with dose response. Dr. Matthew Philippe was actually involved in this study. This study again was in multiple centers in the US and in India, and they showed that the primary outcome was time to solid food was achieved in moderate to medium and high dose Oxera. Very importantly, it showed that with 1 milligram per kg and 2 milligram per kg dose, there was significantly lower results. The company is now planning a randomized trial of this medium to high dose in patients with severe pancreatitis to decrease and improve outcomes by inhibiting the immune functions and decreasing inflammation to improve organ failure. Among the other promising trials, there are 2 trials on steroids ongoing. One is in China, the other is in Harvard. Now, we did a experimental model of severe acute pancreatitis in a rat by giving L-arginine and pacnate duct ligation model. This is the duct ligation model and gave L-arginine. And we measured direct markers of organ failure in that, not indirect. Direct marker was invasive blood pressure, heart rate monitoring, oxygen saturation, pH, and creatinine. And we found in this model that therapeutic steroids were beneficial. Therapeutic means they were given after acute pancreatitis was initiated, not before, not prophylactic dose. And based on the other evidences from the literature, we have now started a randomized trial of steroid therapy in patients with severe acute pancreatitis for resolution of organ failure. This is again placebo-controlled double-blind study funded by ICMR, 5 centers in India, and sample size is 202. Methylprednisolone is being given for 7 days, and our outcome is time to resolution of organ failure. And we hope some good results in the next 2 years or so. So I'd like to summarize by saying that improving outcomes in acute pancreatitis is extremely important to give optimal hydration, adequate analgesia, and early enteral nutrition. Organ failure determines the outcome in those with severe disease. It develops because of dysregulated immune response. We need to develop targeted therapies, and I'm hopeful that in the next 3 to 4 years, we'll have some therapy to prevent organ failure and control it. There are many promising drugs are under development. What I have not discussed today is infected necrosis, where we all know that minimally invasive endoscopic intervention is preferred. And I will just refer you to multiple RCTs, but this is the summary of treatment in those with infected necrosis. You have infected necrosis and fluid collections at the stage of walled off necrosis. You can either do endoscopic transmural internal drainage, preferably under EUS guidance and by placing a LAMPS. And the advantages are there is no fistula development and shorter hospital stay. But those who have collections away from the lesser sac or extensive collections, you may have to do percutaneous catheter drainage. And this percutaneous route can then be used for VAD or may lead or use of percutaneous endoscopic necrosectomy with a flexible endoscope, which we have shown is very effective. And these are the minimal invasive techniques by which we can treat infected necrosis. So this requires a separate topic for discussion, perhaps at a later date. So this is the slide I showed you in the beginning, but what we are looking in the next 10 years or so is to develop therapies to prevent necrosis and anti-inflammatory treatment to target organ failure in this. And my hope is that we will soon achieve that. When you have to treat a patient with acute pancreatitis, as Dr. Matthew Philip mentioned at the beginning, you need the help of an intensivist for sure, but there has to be a large team of surgeons, nutritionists, interventional radiologists, infectious disease expert, and GI physician. I tell you today, majority of patients, as you would also agree with me, have drug-resistant infections, and having an infectious disease expert is of extreme importance in managing these patients well. I'd like to acknowledge my mentors, Professor Tandon, Dr. Saluja, and my various colleagues at AIIMS and other institutions, and my PhD students and funding agencies. In the last, we will all request you to please register for World Congress of Gastroenterology being held from 30th September to 3rd October at Yashobhumi in New Delhi. And I'm happy that we already have more than 800 abstracts and more than 1,200 registrations. We are expecting a total attendance of more than 3,000 to 4,000. This perhaps will be the largest conference of GI ever held in India. 5 national societies are participating along with WGO to organize this. And I'll urge all of you to register now and don't wait for a later date. Thank you very much for your kind attention. Happy to take questions from here.
Thank you, Professor Garg. And Sujita, please proceed with the questions. And I think there are so many questions, and we are so happy that almost 500 people have joined for this webinar. And I'm sure questions are coming up. We have 15 minutes for question and answer now. So Dipta, please take over.
I hope there are a lot of questions, and after you have covered this topic extensively from the length and breadth, and we understand how complex a management of acute pancreatitis is actually. So I will now, this section, I thought that I'll just stick to questions which have come primarily from management aspect. And to start off with, the first few questions are primarily on the first is as in terms of there's a question, sir, which has come, and I think it's important from the periphery. The doctor who's working in the periphery, actually, So his question is like wherever he's working, there's a high intake of alcohol and alcohol pancreatitis. So I think he's having a challenge as regards to admission in ICU and in a resource limited setting. Like what criteria do you use for ICU admission in a resource limited setting? And his other question was also in the role of procalcitonin in the first week of pancreatitis. I think relevant for a person in the peripheries actually, sir.
Good. So with regard to patients who come in with, say, alcoholic pancreatitis, by the way, everywhere alcohol-induced pancreatitis is increasing all over the country. And this is rather unfortunate, but this is something that we have to live with. One of the major problems in the patients with acute pancreatitis because of alcohol is that they are often malnourished. They have multiple nutritional deficiencies, and that makes life difficult for them. So anybody with alcohol or any other etiology-related acute pancreatitis with organ failure should be managed in ICU. Whether or not you have a smaller hospital or large hospital, you have to have organ support. So when I say ICU, you basically need to have three things with you. One is a continuous monitor, where you monitor the heart rate and blood pressure. The second is availability of a ventilator. And after COVID, I think ventilators are available all over the country, even in smaller places. And third thing is dialysis. So fortunately, not many patients require dialysis. They may require ventilation, but not many patients require dialysis, but you should have that facility. So regardless of the etiology, anybody with organ failure needs ICU admission. Persistent SARS alone, you may not admit in ICU, just observe in the regular ward with the monitor and carefully observe this patient. Coming to the second question about the role of procalcitonin. Now, procalcitonin doesn't have much value in the first week of illness with regard to the need for treatment with antibiotics. Procalcitonin also increased in sterile inflammation. But from second week onwards, when your systemic inflammation is coming down, then is a time when if procalcitonin is rising and patient has fever and rising counts, it can be taken as a marker for developing infection, and you may be justified in starting antibiotics. A randomized trial has shown that PCT-guided antibiotic therapy is helpful in patients with acute pancreatitis, which has been the case in other infectious disease as well.
Dr. Garg, for a baseline value of procalcitonin, is it better to do in the first week one value and then second week onwards? Actually, the study also actually shows that you have to do one value in the beginning, maybe normal. Then depending upon that only we look at the progression on the values. Don't you think that first week we should not do, or we can have a baseline value?
So as I said, in the first week, if you have a value of PCT which is high, say 3 or 4 or 5,
we do not treat.
We should not treat it. But second week onwards, if your value comes down, so say 1 or 2 or 3, and then starts rising again, that tells you that likely infection.
Yeah.
So PCT has to be measured serially. It is guided by clinical problems. You suspect infection now, you measure it, you find it is high, you start antibiotics, then it can guide you. You measure it again and see whether it is decreasing. That tells you, okay, now I can stop antibiotics. So serial measurement is important.
Thank you.
So the other question is primarily related to the pain management, and I actually just joined many questions together. So the one question that came out very thing is that in this sort of situation, in acute pancreatitis, is it a stepwise management of pain that you do, or we go upfront with opioids in this patient? And the other question in that context is fentanyl patch as effective as fentanyl infusion? And how do you do a dose titration?
Okay. So in terms of the choice of analgesics in the beginning, I think it will depend on physician's assessment of the severity of pain. If the physician feels patient has significant pain, I would say upfront go with opioids, right? But if you have a mild disease, pain is mild, you can even give paracetamol IV, or you can try diclofenac. But my preference here would be weak opioids like tramadol. But someone who has severe pain, doesn't respond to tramadol, the rescue analgesia of fentanyl should be given to these patients, ideally with an infusion pump. Now, coming to the patch, no, I'm not sure if there is a head-to-head trial between patch versus IV in acute pancreatitis. There could be trials in the post-operative setting that I am not aware of, but clinical experience tells us that patch is not as good as IV. So we prefer IV fentanyl as rescue analgesia, preferably with a patient-controlled analgesic pump. And I tell you, this PCA pump is not expensive at all. It only costs 2.2 to 2.5 lakh rupees, and it is very, very efficient.
I completely agree with you. We have been using patch in certain circumstances, and it takes a time duration for it to start efficacious and not particularly very effective in the initial stages when the patients come in severe pain. Uh, Sir, I'll just move on because of the shortage of time to many questions which are coming in management. So, sir, as you have elaborated, sir, there are many therapies which are now currently in vogue. Like you spoke of steroids, anti-TNF, and cytokine absorption agents and all. One thing which is now quite commonly used in certain circumstances is ulinastatin, sir. A lot of questions have come in on the role of ulinastatin and actually should it be used.
So ulinastatin came with some promise. In fact, there was a randomized trial from India which showed that it might be helpful in preventing post-TRC pancreatitis. But the data from the literature is not very supportive of its use to decrease systemic inflammation and organ failure. My short answer would be that as of today, we don't have enough evidence, but one may try in a randomized trial and see whether it is effective or not.
While sticking to the same aspect, sir, the other two questions have been mainly on the role of pancreatic enzyme replacement therapy in acute pancreatitis. Whether there is a role and should we give it at all?
So there are two aspects to this question. In fact, Dr. Chaudhary is the best person to answer because he's now started a randomized trial, which is ICMR funded. One is that during hospitalization, those with necrotizing pancreatitis obviously will have a lower enzyme levels because most of the pancreas is necrosed and they are on enteral feeds. So whether or not enteral giving these pancreatic enzyme will help nutrition or not, we are not sure. And that is why Sudipta is actually conducting a randomized trial. The second aspect is after recovery from pancreatitis, when they are discharged, if you see their fecal elastase, you find those with necrotizing pancreatitis, their elastase is low. In fact, as high as 60 to 70% patients will have low fecal elastase. So giving them enzymes along with a nutritious diet, I think practically is a good option. Fortunately, when you follow up these patients over 1 year or so, majority will have recovery of the pancreatic exocrine functions as opposed to endocrine functions. So endocrine functions do not really improve much, and 30 to 40% develop diabetes, but exocrine functions improve over time. And so in the first 3 to 6 months, if you give enzymes with diet, I think it's a good strategy. But we don't have much data from randomized trials, and I'm happy that Dr. Chaudhary is conducting this trial, which will give us some solid answers.
Thank you, sir. I think this is one area of active thing, but we still don't know. So we're looking forward to this trial reaching its conclusion. So the other questions that have come primarily are related to organ failure in the first week of acute pancreatitis. And one of the questions that is important, and we have seen it, is actually patients who have hypertensive crisis during hospitalization. And we have seen it, and we in fact we published also in the past that patients do develop acute hypertensive crisis during their thing, and those with hypertensive crisis do not do well. So your experience in acute hypertension during in the ICU stages in certain subsets of patients with acute pancreatitis who develop a hypertensive crisis.
So I'm not sure that hypertensive crisis is something that we see commonly or rather uncommonly. So patients who have got acute renal dysfunction, we have found that of course they are hypertensive. The other group of patients in whom the blood pressure is on the higher side is those who had hypertension to begin with, but not on treatment because it was never diagnosed, and now you find their blood pressure has gone up. But real hypertensive crisis, I don't think is seen commonly in patients with organ failure. But if someone has, of course, very high blood pressure, you have to bring it down, regardless of what is the underlying cause. But renal failure is something that we have seen patients coming with very high blood pressure, diastolic reaching up to 110 or so.
We have noted that in the subset of patients who develop the TTP-HUS type phenotype in acute pancreatitis, they tend to have this sort of situation. Another situation where we have seen it encountered is patients who come with alcohol withdrawal and they are agitated. And I think that that hypertension is primarily alcohol withdrawal driven rather than the disease per se.
Right, I agree with you. And I think let's dwell on that, what you just mentioned about HUS kind of a microangiopathic thrombocytopenia. TTP-like situation. So it has been seen that many patients with acute pancreatitis may present with a picture similar to TTP, and these patients may benefit from specific therapy like steroids or plasmapheresis or IVIG. And Dr. Chaudhary has actually published on that the role of TTP in acute pancreatitis and how you can treat that. So I think this is something, and low platelet should alert you to the possibility of having TTP in these patients.
The last two questions are mostly related to the management in the second week, as in terms of antibiotic strategy and how to start the antibiotics and whom to start antibiotics in. And in that context, I have a question also, sir. Because certain patients come in with hypotension, and our experience has been those patients come in with shock tend to have a very poor outcome. And in those circumstances, despite them being in the third day of pancreatitis, our ICU protocol dictates that they should receive antibiotics, and we have been giving antibiotics because we don't know how to treat them, so therefore we are giving antibiotics. But other than that circumstance, is there a strategy that you use to start antibiotics in acute pancreatitis?
So I would say that in the second week of illness, now if you find a patient who is not improving towards the end of first week, you have to be careful. You have to be mindful that this patient is likely developing a secondary process. So those who have got first week organ failure, gradually the systemic inflammation start decreasing, because that's what the defensive mechanism body is. The CARS, the compensatory anti-inflammatory response syndrome, sets in the later part of the first week, and that brings down the inflammation. If you find in the second week onward, the patient is not improving or now deteriorating, developing fever or raising counts, these are the patients who are likely developing secondary infection of the necrotic areas. And you are justified in starting antibiotics if there is fever or rising counts or increased procalcitonin, right? This is the second week onwards. So even if you don't prove, so this is the concept of suspected infected necrosis. You really don't have to prove infected necrosis to start antibiotic. You suspect it in the second week onwards, then you can start antibiotic. Now, with regard to the hypotension, I completely agree that those who come in with hypotension, which is not responsive to fluid resuscitation, this is important. Not responsive fluid resuscitation, you are dealing with a very, very grim situation here. Cardiovascular failure in patients with severe pancreatitis has a bad prognostic marker. Very important to remember that. In elderly, you should rule out if they have underlying cardiac disease, heart failure, arrhythmias, or myocardial infarction. And don't give too much of fluid to these patients. You start vasopressors early during the course of the disease. And if you find patients' counts are high, obviously they are high. If you give antibiotics, it is okay. I mean, you're not going to cause much problem. If they have multi-organ failure for 5, 6, 7 days of illness, you can't prove or disprove infections. I mean, giving antibiotics is no problem there.
So the other aspect, of course, is which is a common thing about gut sterilization, use of rifaximin. Is there any role of that in acute pancreatitis, considering that the gut translocation is the source of infection?
So rifaximin again has been tried, and the idea there is that can it prevent secondary infection? So there is some theoretical basis for that. And recently, a randomized trial was published in Pancreatology. In fact, this trial is from Odisha in India, where they showed that there was not much benefit of this. But again, there could be issues with regard to the inclusion of patients, inclusion criteria, the dose, the duration of the therapy. And I think, again, it's an open field whether rifaximin is going to decrease infection or not. And we need a large multi-center, perhaps a multi-center trial to see the effect of rifaximin in preventing infection. So again, an open field here.
And I think the other few questions are maybe in the use of antifungals in acute pancreatitis. I think that was already. So, when do we start antifungals in acute pancreatitis? Do we start them empirically managing severe disease?
So antifungal again is becoming very common nowadays because there are a lot of patients who are coming in with fungal infections. But prophylactic use of antifungal is not recommended. That's one statement. Second is those patients with necrotizing pancreatitis who are in the hospital for more than 4 weeks or so, they have a high chance of developing secondary infections. So you should differentiate between pancreatic infection, which is invasive, or which is only colonizing, say, for example, a percutaneous catheter. So colonization should not be treated as invasive fungal infection. In a prospective study, we found about 10% of patients had invasive fungal infection, those who had necrotizing pancreatitis going on for weeks or months together. There was a meta-analysis also published which showed somewhat similar results. So if a patient is in hospital for more than 4 weeks, 5 weeks, you have given antibiotics, your culture is not showing any organism, PCT is not raised, counts are not raised, there is still ongoing infection, I think you should give empirical antifungals. And if your blood culture shows, definitely so.
Now, we have been relying on the beta-D-glucan sometimes to see whether that shows infection, but that cannot differentially discriminate.
Yeah, it's not really very good. Yeah.
No, not at all, sir. So, Matthew, sir, any other questions that I would have missed from the chat?
I think we have to close. I think there are some other questions again on unistatin and enteral nutrition, etc. I think you have covered many of that, and unistatin is already answered. And I think it was a wonderful session, Dr. Garg. It was really a great session and on the predictors as well as on, especially on the early interventions, how it can prevent. But I agree that if you add on to necrotizing pancreatitis and pancreatic necrosis, it becomes a bigger one, and we can have another session on that. And Sudipta wonderfully moderated and addressed all questions if possible. You have clubbed the questions so well. I'm so happy that you're also involved in many of these studies and original trials on pancreatitis. And we have the stalwarts of pancreatitis or pancreas from India today together here. One is the speaker, another is the moderator. I'm sure it will change.
Including yourself.
That's okay. And I'm so thankful to and I'm so happy that we have got very good participation. It is not only from India, from across other neighboring countries also. I have noticed them, Malaysian has also joined here, and Malaysian doctor also joined here. So it is very happy to note that our this masterclass is getting momentum very well and is well accepted. And as I would like to thank both of you, as well as all the participants and the tech team for giving all the supports and the silent support of Mrs. Nisha, who has been doing all the groundwork. And I urge us, Dr. Pramod, who has kept, please register for this wonderful conference. It is going to be really a great conference, and your participation really makes a lot of difference for us. And since it is happening for the first time in India, we have to show our strength in gastroenterology, and all the societies are joining. 5 societies are joining together, and I encourage all the HODs to send their postgrad students, and all the postgraduates who are joined here, please do join. And I'm sure that the AMA students, their final exams will be over by that time. So please do join for this one and send more abstracts. And we are so happy that we have got 800 abstracts, and we need more registrations. Please do join and don't wait for the last moment. And the prices may go up. And abstract you have to send in the right time, only few days left for finishing off. Once again, I thank you, and Dr. Garg for your time and your wonderful talk. Dr. Sudipta for the kind moderation. Thank you so much. We'll see you again with the next talk in another few weeks' time. Thank you so much. We'll be having this session.
Thank you very much for listening. Thank you.
Yeah,
Namaskar.
thank
Bye-bye.
you. Thank you.